care in so many ways. But about 50 years ago or so, in the 1980s, we saw this focus on enterprise-wide efforts at improving quality and safety outside of healthcare. And leaders in healthcare began to recognize that we could use some of those same ideas and insights in healthcare service. And so the question changed from how might we establish thresholds for good healthcare service to something like how might we use enterprise-wide systems for best disease or condition management. And about a decade ago or so, people began to notice that the question was in the process of changing again. And the question seemed to be moving toward this concern about the value of the efforts that are involved. So the question became something like, how might we improve the value of the contribution that healthcare service actually makes to health? And the chapters in this handbook that Peter referred to that are pertinent to these last 100 years of work are indicated in red after the themes. And what you see is a wide smattering of information that's available to the reader of the handbook. Now, because we're focused on 3.0 doesn't, of course, mean that we've no longer got concerns about 1.0 or 2.0, but it's rather an addition that we are now able to see how we can improve healthcare with the use of all three of these questions. So I look forward to this conversation. Thank you very much, Peter. Welcome.
Yeah, thanks a lot for the introduction. Just before we take the slide off, the key thing that we want to point out today is that many people who may be listening are involved in regulation and accreditation of their facilities, which is very important. This is the 1.0. And it's the foundation. You do need it. It's not saying, well, if we move to 3.0, you can get rid of 1.0. And that's what Paul was really emphasizing. If we could just get to change the slides and maybe get into the full discussion. I'm going to start a question, and I'm going to put it to all of us, is what do you think the main challenges are for quality in healthcare today? And I put it open to anyone who wants to do it, but I would say that having just come from spending time at the IHI conference, IHI-B&J conference last week, and I've been at the ISCRA conference last year, it seemed the main was how people treat each other. It was the main focus on kindness and respect. What do you think, Pat?
I think also since post-COVID, there's we're working so many different ways now. And I also think, particularly if you think from a UK perspective, there's a great strain on resources. So we're not as rich either in people or in skill or in financial terms. Each service is quite restricted upon what it can do, because there have been huge changes in all of these since the impact of the pandemic.
Paul?
So I think that one of the challenges we have faced is this full integration of a concern for quality into the daily work of being a professional. And we live in this overstimulated world, and it's important that as we live in this overstimulated situation, that we remain focused on what's truly important to people and the people that we are in the midst of.
John?
Yeah, I mean, I think building on the points that Paul and Pat have made, I mean, I think accessibility for everyone in healthcare and everyone involved in healthcare, patients, their family members, carers, accessibility to, more effective and more efficient ways to improve how healthcare service is provided, I think has always been and continues to be a key challenge. And I think that's one of the most remarkable things about this book and how you've encouraged us as authors to approach writing it. It's all about making it accessible, and not getting bogged down in dogma, but rather recognizing there's lots of different elements to this. It's incredibly complex, and we all have to be flexible and adaptable in how to address the big challenges that we're faced with. Picking up on the point of resources, I mean, there has never been a greater demand on efficiency of time for people working in healthcare. I mean, healthcare provision is mostly what I do, and there's not a minute to waste on any given day. So we have to be maximizing, the effectiveness and the efficiency of the work that we do in improvement and safety. And again, I mean, I think this book is a wonderful resource in helping people faced with that real world context realize that best efficiency and best effectiveness for their efforts.
James or Sinead, you want to add?
Yeah, I can add there. So I agree with everything everybody has said. I think that for me, demands have never been greater. As a clinical microbiologist, COVID hit hard in terms of demands. But I think that what is central is keeping what's important in our heads as we're doing anything within quality. So not to be focused on standards alone, but it's actually how they affect people. So not only the patient or the caregivers, but also the professionals that we're working with. So I think that focus on kindness to others is really important, that we remember that as we're trying to improve safety for patients.
Peter, I might offer an observation, maybe as a little bit of an outsider for someone who doesn't work in clinical services, but is obviously interested in how they work and how they improve. My experience in cancer screening, at least in the Irish context, has been that I've seen places where services have really improved very dramatically, but it's kind of relied on the presence of determined individuals who saw problems and were really confident to make the change, and they probably needed to be. They need to be senior clinicians who are the people who get a system to change. I mean, and that's wonderful when that happens, but I think a system that relies on determined individuals who've got the time and the energy to go and do that, I'm not sure if that's the healthiest way to do it. And I think a system that systematically prompts service improvements continuously, that doesn't rely on those determined individuals, is what we need for sustainable improvements. And I think I can quite honestly point to the book as an enabler to that, because I think it empowers people to understand, what are the levers of change that need to push, and it provides them with a roadmap for doing that. But I wouldn't still want to discourage those dynamic individuals who want to lead, though, at the same time.
Yeah. I mean, that's a great observation, James. And I just want to point out something you kind of mentioned yesterday, is that every system, no matter how much resource you have, always says it doesn't have enough resource. And I do a lot of work for the health service in Ireland, in Africa, in the global service in Sudan, Mozambique, Ethiopia, Tanzania, and they've got far less resource than we have, and the same problems. So what we try to do in the book was make it not upper income country centric, but applicable to wherever people work. So the interventions can be done with low resource as well as a lot of resource. And one of the things I just want to point out, because we're all from upper income countries here, is that for me, in many parts of the world, the major challenge has been the destruction of healthcare services as we know it. So, for example, I was in Sudan just before the coup, not before the civil war, and so all the hospitals I visited have been destroyed. And what's going on in Gaza, all hospitals have been destroyed, and it can go around the world. There are many different places. There's just two that I know about very closely. So we've got to think about how we can apply things at any different area. So the challenges are different in every place, but the context, the theory, and the methodologies that we have in the book apply anywhere. So that was the main thing. I'm going to just jump to a question that we have here from Mohammed. The value question from healthcare quality does pose a challenge in resource-constrained parts of the world. It's not always practical to put quality and safety first. Any thoughts about that? And I'm trying to address that. Mohammed, I've worked in Mozambique with people who have very little resource, and they've applied the theories in this book. And in the one hospital that I worked with, they decreased mortality from 10 people a month in their ward down to 1 or 2 a year. And that was just by applying the theory with no extra resource. Because if you empower people, and this is where the co-production part comes in, if you empower people to co-produce safety and quality, then they can do it with less resource than you really think you might have. So in our answer is, it's important for us to look at how we can utilize the resources we have in the best way. And the book, I think, does help you do that. I hope that answers the question. Pat, do you want to take the second question?
Yeah, the second question says, thank you for the book, and what's the best way to get QM issues at grassroots of overworked and time-strapped health professionals? How do you motivate them to change? They have the tools, but how do you motivate them? Well, one question that's always asked when people are trying to focus on safety and quality is how much repetition and waste is in the system. Because often if you're a patient or you're working in a service, you do things multiple times when maybe only once can do. So looking to see where efficiencies can be made. I know teams do that all the time, but that's one way to free up a bit of time to think about quality and safety. Because it's often very unsafe when you continuously repeat the same tasks or the same information, particularly if you think about a patient admitted to, let's say, a hospital. Often we ask them the same information at least 5 to 10 times, depending on their patient journey. So that's one way to do that. I don't know if anybody else would like to add to that.
Can I just link that to a question Paul would pose about curiosity, Paul?
Well, I
to me, it's about how you get curiosity down. So over to you, Paul.
Yeah, I think so. I mean, in the book on page 16, it has a set of things that leaders can do, but I think everyone can share their curiosity about what's going on. One of the ways that I've found very helpful is just to invite somebody to observe what's going on. A nurse that worked with me was very helpful to me as she observed what I was doing and the stupid ways in which I was going about what I was doing every day. And so inviting an observer to just sort of watch what you're doing and tell you what they see is a very practical, helpful way. Another way that I find helpful is in a moment when I'm waiting somewhere or when I don't have anything else to do that moment, I just make a note about it. And it's a little note to self about what I see, what I notice, what I observe. And so I think it has to start with the curious person.
John?
I might come in there as well briefly. I mean, I think a lot of this as well is about connection to purpose. I mean, I love in my work, with doctors in training in Ireland, I get to give a lot of them their first exposure to, defining quality and pitching quality improvement as an approach for making things better. And in that introduction, it's recognized that a lot of people see, the quality or patient safety department as being a group of people with their own way of thinking and their own language over there. And if they hand me, a form that I have to fill in or whatever, that's just another job or just another task or another big ask on top of, all of the other demands on my time. So, I mean, I think a huge part of this is, how we translate it and how we work with this idea of purpose. Because in healthcare, if we're not always trying to come up with better ways to make care safe, timely, effective, efficient, person-centered, and sustainable, then what are we trying to do? So yeah, I think that can be a really useful way, getting into that space.
Yeah, and this covered a lot of areas that if you, in chapters 10 and 11, which Pat led on with Catherine and Amida, this is where we really look at how you can get people hooked into the quality improvement. And I think the key is this curiosity, is people being curious about how they can get things to work and what's working and what's not working. But what I thought that we need to just move on. There are lots of different questions here, and I'm going to throw this one about patient safety and quality being from Jim Little on being run as parallel tracks. So we've got a handbook of patient safety, we've got a handbook of quality improvement. You might say we reiterating it, but actually it's the same authors integrating what we're trying to do. But anyone want to talk about this parallel track? Sinead, do you think, or?
I suppose I always see them as being the same, as being, as you say, two sides of the same coin. They are the same thing. I suppose it comes back to when that last question was about how do you get people motivated. It's what's important to them, is how you motivate people. And if you're motivated by just quality improvement, numbers, improving statistics, improving standards, that's your motivation. But if your motivation is the patient, that's patient safety motivation. You're actually working on the exact same thing. But I don't see them as being different. I do think that they work together. It's just how you see it.
I see Pat and Paul.
Yeah, I think from a patient's perspective, if you've ever been a patient, you want the care to be obviously safe, and quality from the patient's perspective is about outcome and how they feel. And I know we talk about both of these things in chapters 10 and 11, and from the patient and family perspective, they want the care to be safe. And I'm sure if the care is safe, then they feel they've had a great service, they've been treated with kindness, and certainly have a good clinical outcome. Then they would report back to us as caregivers that was a high quality service. So yeah, what I'm trying to say is, from the patient's perspective, they probably don't separate safety and quality. It's merged into how they feel and what their clinical outcome is.
Paul?
So each of these are windows on the work. And these windows on the work offer us an opportunity to see the work and to work on the work. And that kind of thing is not limited to healthcare. I mean, Paul O'Neill, when he was the CEO of Alcoa, wanted to focus on safety, and everybody said, "You're crazy." And he said, "No, I'm not. I actually want to work on the work." And so he invited people to tell him about how the work could be safer. And he got into the work. And it was a prescription for actually leading a focus on the improvements of the work itself. So I think each of these are important windows that we can use to look at the work.
Thanks. John, do you want to add something there?
Just a very brief point, Peter. I mean, I have both books here, and I have two back pockets, and they'll fit in each one. If I try and put it all together, it's too much to digest.
That's great. And just to say that John was a co-editor with me on the safety book, and Pat wrote a chapter as well. So did James. So I'm just going to jump to James, because often people forget about health economics and where does that fit in with patient safety and quality. And in chapter 7, we have a focus on health economics. So what do you think the relevance of health economics is, and how you work the cost effectiveness of quality improvement and patient safety? Because if it's not cost effective, then people won't do it as well. Or how do they know it is?
Well, thanks for the question, Peter. I suppose, and I think it's important that we seek to apply health economics to this area, because I mean, I think health economics is largely developed around the appraisal of drugs, and it's been about maybe trying to control the growth of drug expenditure, and maybe it becomes it gets reduced to that function, whereas it can offer very useful insights to lots of aspects of healthcare services and their improvement. So it's good that we didn't lose insight, and we sought to how to apply the methods here. I think one of the challenges are when all of those methods of health economics have primarily been developed around drug appraisal, we have to think about how do the broader principles, how do they apply to system improvements? And I think the challenge maybe comes back to clinician time. If we talk about people who want to drive change, they've got to do their very, very busy work. They've got to maintain excellent clinical standards. They have to try and maintain the motivation of the staff who work in their unit, and that can be very, very challenging at the best of times. And they have to try and find the time to assess projects that they're looking at. And I think that's a really difficult ask to get people to do things who, if you don't have a prior health economics training, how do you get up to speed with understanding the terminology? How are you going to frame your improvement, the improvements in what you're doing? So I think it's about trying to break down the concepts, make them as accessible as possible to enable people to think about how the projects that they're working on, the service improvements they're trying to drive, how can they document them, make a very strong business case, to the managers that they'll need to speak to about those processes. So I think maybe demystifying and getting people to focus on the what are the real key principal components that they needed to capture in their projects. That's probably what I would sum up as my answer there, Peter.
Yeah, and that's what that chapter actually does. It was written, James, we had 3 health economists and 2 people who didn't know much about health economics write the chapter to demystify what the economists were saying to us. And that's how the book is progressed, to make it easier for people to understand. But I'm going to link it to a question. I'm jumping around the questions over here about telemedicine, because cost effectiveness has always been with telemedicine. It's maybe more cost effective, but it adds a safety dimension. So the question is, what do you think about quality in telemedicine hotlines in Africa, keeping in mind patient safety and co-production, and how can we get in? So this is open to audience because this is very new. So I'm going to go back to the other questions as well, those who asked before this one. But I thought we could tie this into James, because I think people often said it's cost effective to have telehealth.
Yeah, I don't know. I might take it away from my own professional experience and go back a little bit more anecdotal. So my mother is a GP, and she mentioned an awful lot about her experience with telemedicine during COVID, and how it was very important to keeping up with an awful lot of her patients in North London. And I think she saw 2 sides of it. I mean, it was very easy to get through lists of catching up with people and so on, but she really felt that there were certain patients, and you really needed to see people in the flesh. And I'm sure all the practitioners listening that'll be very, very familiar. And so I can see how that can apply to a context where maybe the distances that people need to travel are very pronounced. So I guess it's that balance you're able to save. You're able to save people their time traveling, and that applies not just to the doctor who may be have to going out to people, but also patient time in terms of getting in. So I suppose many more people can engage efficiently, but there ultimately will be a time when you really need to see somebody in the flesh to really provide them with a proper assessment. So yes, I think there's no neat answer to that. I think there's always a balance. We will need to see people face to face.
Paul, yeah.
So doing more or doing better with less is not a new idea in healthcare. I mean, we've been working on, that's what led to the formation of clinics, where it was possible to see more people because you weren't traveling by ox cart to somebody's home. And my sense is that this idea of seeing our work as the transfer of information and the use of information as inclusive of whatever techniques we have to move information reliably and safely and to use time better is just been a long time part of our work in healthcare service. And of course, we have to deal with these challenges of safety that come from access to the transfer mechanism or transfer process. So whether it's somebody looking in a medical record or a file that didn't have proper access for that, or whether we're talking about protecting the channels of information, is I think just part and parcel of what has always been important as we do this. We have to continue to try to use this technology, as we've seen the benefits of being able to access somebody for a little question, not to take over a whole day by getting a simple question answered.
John, you were in COVID. You obviously were doing telemedicine. You're the only one of us who probably was doing it all the time.
Yeah, and I mean, again, I suppose I've a number of different kind of thoughts and perspectives on it. I mean, I think it can work incredibly well where you have continuous relationships with patients, which we in general practice are very lucky to have. So, you're building lots of small interactions over longer periods of time, and phone calls and emails and, other bits of information that feed into that story are really, really useful. I suppose on the other side is, this idea of innovation and how it is often disruptive in many ways. It creates incredible opportunities, but it does also sometimes create these, conflicts between quality aims, right? So we can improve maybe timeliness and efficiency with telemedicine, but do we compromise on effectiveness or safety? How do we think about those different conflicting aims at different times? And again, I think, coming back to some of the basics on systems and understanding them and measuring them to improve them, I think is key. Because, we're not gonna stop more IT delivered healthcare, and AI delivered healthcare into the future, but it's about figuring out how we can consistently improve it in terms of quality.
Sinead, as a clinical microbiologist, I'm sure digital health and AI and telehealth is affecting you.
Yeah, and I think like everything, it's a tool and it's not applicable everywhere, and it's very much how we use it and how we measure whether it is doing what we want it to do. Is it providing efficiency? Is it providing timely care? But is it compromising something else, just as John was saying? So I think that I agree, we can't stop it coming. It's here and it has its place. But like most things in quality improvement, you have to pick the right tool for the right job, and just make sure that you know what it is that you're trying to achieve with it.
Yeah, and I could just add that in the book that we started off with the quality 1.0, 2.0 to 3.0. If you have telemedicine, you do need to have standards. That's quality 1.0. And then you need to have quality 2.0 and how you implement. And then you're going to have quality 3.0, how you co-produce the outcomes. So you can apply it to telemedicine. And so I'm going to jump very quickly to Shannon's question, which is quite interesting. What are your thoughts and advice on leading system-wide health and social care programs that all use different methodologies? And I'll just, before I throw it out to everyone to discuss, I'll say that this book is based on Deming, and you can see that it's applied Deming because it's not exactly the same. So we have chapter 8, which will be the lens of chapter 10 and 11 is the lens of psychology. Chapter 14 is the lens of knowledge. Chapter 13 and 15, the lens of variation, and the chapter that Sinead wrote, chapter 10 is the lens of systems. So, and that says so in the book. So we are tied to Deming, but we also applying it. We also taking to the next level on co-production. So we put in like a matrix with co-production running throughout the book. But open to everyone who wants to comment on that question. John.
Might come in first on that, Peter. I co-authored chapter 14, as you said, which is the lens of knowledge, where we look at quality improvement methods. And I suppose the approach we've taken there is that we've, outlined the model for improvement, Lean, Six Sigma, theory of constraints, experience-based co-design, improvement collaboratives, improvement through human factors. We've tried to, I suppose, demonstrate the menu in a way of what's available, we've tried to do it then again with examples. So how the theory of constraints might work if you're looking to improve flow through an emergency department, how experience-based co-design might work if you're looking to improve the outpatient experience in a psychiatric unit, how we used improvement collaborative methodology in our national COPD improvement collaborative. So, as Sinead just mentioned a minute ago, it's not about, being dogmatic and sticking rigidly all of the time to one methodology, no matter what problem you're faced with, but recognizing that there's lots of different approaches out there, and they can be used exclusively or sometimes combined to best effect or best use. The other thing that might be of interest to Shannon on that chapter, and one of the things I'm proudest about in that chapter, is that we've also listed the limitations. So sometimes, at improvement gatherings, everyone can be waxing lyrical about this way and that way and the only way to kind of do things. But sometimes, the critical thinking or the curiosity on why things might not work is lacking in the discussion. So we've included that. We've made sure to include some limitations to help people when they pick up the book in deciding what improvement approach might work best for their problem, to help them evaluate and think about that in a little bit more detail.
Paul?
Well, sometimes healthcare seems like making a product, and sometimes making healthcare service is actually a service. And the logic of making a product is I make it, you buy it. And the logic of making a service is we're actually doing this together interactively. And so this one size fits all risk that John was just alluding to, I think is key. Many methods will help us, but we have to understand what part of healthcare and healthcare service we're actually trying to work on, and what our assumptions are, and what the logic is that actually informs the way the work goes on.
Pat?
Yeah, just to add to that, I mean, context is everything. Where you are, how you work, how the people around you work, and how they feel about the work is so important when you're trying to find a way to make a change. So one of the things to draw people together, regardless of how wedded they are to a model, is to find a common purpose, to agree on this is what we want to change. We all agree that this is not working right, or it can be better than it is, or we all want to work on this because we know it'll make the service better, or this is what the patients and the families want. And when you find that common purpose, and then you look at the context, you can do, just as John's mentioned, use different models to achieve different things.
Thanks. I'm going to just jump to a question, and I'll start, I think, with Sinead with this question on professional development, because I know Sinead's working at a university. And and the key thing is quality to be the question I've just jumped about. Sorry, quality is about standards of care, and does working to improve quality being the same as professional development? So should it be part of the professional development of all students and so on as
Absolutely.
they do quality?
Yeah, absolutely. But I don't think. I suppose it depends on how you label it. We should all, coming back to what Paul was talking about, embedding that curiosity in your students early. It's not, sometimes when you label something as professional development, it sounds like something that just needs to be endured and you need to develop. Whereas if you've got a curiosity, or inspire your students to be motivated to look for better ways of doing things, improved ways of doing things, then it's not something that they have to tick a box to answer a question. It should be something that they incorporate into everything that they do. So I think that we should be incorporating it from as soon as they they come into us in university, we should be trying to inspire them to continuously look for ways to improve everything that they do. And that will improve their professional life, but also their patients' outcomes.
James, you also at university, so you could.
Yeah. Well, I have an anecdote on this that I'm very proud of. So years ago, I did a project with a group of medical undergraduates, and we were looking at cost effectiveness analysis in some way, in some domain. And the student went on to do further clinical placement during their undergraduate medical training. And I just happened to bump into her, and I said, "How are you getting on?" And she was telling me about how her clinical placements had gone. And she was just talking about the use of medicines, and there were certain interventions that she could see were being used routinely. And even though she was very junior, she realized that there was very, very little utility in the things that were going on, and that these were costly. And she stopped and she asked people, so why did we do that? Because all of this took time and money to do. And I was so proud that she was thinking of the resource implications of unnecessary aspects of care, or aspects of care that had probably very, very little utility. And she was comfortable in asking those questions. Now, that's not easy as a junior. She's not even medically qualified yet, but she was comfortable in asking those questions. And I think it's about that mindset that people look around for improvements at any point in time and think about, why are we doing this? Is this necessary? Do we need to change that? So I think, that stuff gets very much embedded in our actual practice and isn't a tick box, as Sinead says. It is really something that we want to go and do. So I think, so the health economics example is just one little example, but it's just that mindset to quality improvement, and that we're constantly looking out for these things that we see, and we constantly question, not in a critical way, but just a way of seeking opportunities for improvement.
So, Peter, one of the things about professional formation and development is that sometimes it seems like we're engaged in preparing soloists, people who in fact are getting set up to do their work. But a good part of what we do is interactive. It's working together with the person whose health it is. They haven't outsourced their health to us. We're working together with them. And so our notions of professional development have to progress so that we actually see that as part of good work in a health professional.
That's a great point to lead on to some of the other questions that we had ourselves. But I'm a very interesting question here about, should quality be outsourced to a quality department, or should there be a quality department, or should there be an integrated department? That's an interesting question. There's also been a response to it as well, saying it's a gamble not to have the quality department. So I'm going to start off. I'm going to start off just by responding. When I was at Great Ormond Street, we set up the quality department, and then we had all the quality experts in the department servicing the hospital. And then we decided, well, no, that's not a good idea. So we kept the quality department, but put all the experts into the different divisions. And after a while, they went rogue, and the divisions were doing their own stuff. So we brought them back in. So the answer is, you've got to have a very flexible model in which you do have a quality department to do some of the hard work. But Paul's famously, I think, attributed to the saying that quality is everyone's job. Is that right, Paul?
Yeah.
You quoted the most on that statement. Yeah,
it is the case. I mean, if we try to think of it as somehow the doctor's job or the nurse's job, I mean, it's a bad idea. It's insufficient.
Yes. So that the answer is, it's everyone's job. You may have a quality department to coordinate and to assist and to motivate, etc. But actually, everyone should be doing quality all the time. The order is John, and then James, and then Sinead.
Well, I suppose I was just going to make a very brief pitch for primary care, where I'm based. We're operating at units of size where it's not even practically possible to have a quality department, and 90+% of all care that happens around the world is in primary care. So it's insufficient in that sense also to be depending on there being a quality department where it exists and it can support and it can help and it can, you know, drive initiatives. Wonderful. But in many senses, you know, with how healthcare looks around the world, it's not practically possible.
And just to say that I'm working with the Ministry of Health in Tanzania to develop quality for their what they call dispensaries, which is a small clinic, not even a clinic, it's a doctor and a nurse in a hut in a village, and they're the quality department. So we're working out how do we train them to be the quality department, because they're the only people there. And then we're going to go to the community clinic in which there will be 4 doctors and 4 nurses or so, and they're the quality department. There's not going to be no quality department. So the process in rural Tanzania is how do we enable and empower the people doing their daily work to be the quality department as well as being the doctor and nurse. Over to you, James.
Yeah, so I think this is a really, really interesting question, and I don't think I've got an answer here, but Peter, I just wanted to maybe probe a bit further and ask another question, and maybe to draw a little bit more out of this, is that if you have a quality department, do they end up being seen as the quality police, and that they are people who come along and are looking over people's shoulders and people are reluctant to show them things? Or can a quality department function as an enabler that people bring in and seek to get support of how to improve things? Because I think I've seen the policing role in other elements where external expertise is relied on, and an adversarial relationship builds up rather than one of co-production and support. So I don't know, from seeing it firsthand, how have those dynamics played out?
Sinead?
I was just going to say that I have a problem with it being called a quality department. Department sounds like it's walled off, it's siloed, it's not accessible. I think that the purpose of quality is that it should be enabling a quality culture. They may be a quality resource rather than a department. Yeah. Because it's not their responsibility. They should be there to aid people in quality work and to give them resources, help, whatever like that. But they should not be the department responsibility or the policing function. So I think that I would rename them as quality resources rather than a department.
That's a great name. And just another issue is that one of the dead ends that patient safety went down is which they appointed risk managers who weren't really managing risk. They were managing the reputational risk rather than anything else, not proactive risk management. And people were very scared of them because they were the patient safety police. And when a risk manager walked into a clinical area, everyone ran for the hills because they thought something must have gone wrong. The only time you see a risk manager is when something goes wrong, not when something goes right, not co-producing safety. Maybe that's changing now. And then, so, I mean, we had loads of questions ourselves, but we got so many from the people. I'm going to ask the next one, which is open to all. Integrate the satisfaction level of service providers with the patient safety and experience of care of those who receive care. Paul, I'm going to start with you because this is a nub of co-production.
Well, I think that once you start to put on the glasses of really making a service, you recognize that one of the lenses is labeled kin or kinship, and the other label of the other lens is task. And so you use both lenses of the glasses in order to see the service dominant logic that's involved in this. And my sense is that once you get that, you see the same in education or learning. The teacher is not responsible for the student learning, and the student can't outsource the learning to a professor. So the challenge is, how do we enable? I loved your suggestion, Shanita, about Quality Resource Group. That was the name of one of the groups that I had the privilege of facilitating in an earlier time. But it is this idea of adding curiosity and creativity and insight that is infectious, that sort of attracts the energy of others.
Anyone want to add? Pat?
Yeah, I think as James already said, some people are instigators, if you like, is one of the words I was used, these enthusiastic individuals that you talked about. But when you think about a quality department, I think many hands make light work. And there are great examples of quality departments or quality resources, or Cecile, one of the participants today, suggested calling it a learning unit, and that's a great idea too. So if people are working in an integrated way and they've got a shared purpose across the organisation and they're driving that forward, I don't suppose it really matters what you call it. It depends how it's seen across the organisation and how the individuals and resources are felt by the people who actually do the work. Because if you see it as a policing resource, and it's quite frightening if I've been a risk manager, so hopefully people weren't running for the hills, Peter, when I went to visit the units, because it was all about patient safety. It wasn't because patient safety then turns into a corporate risk. So if you deal with what's happening at the front line, I think that's the most important. But I think when people feel included and they're working towards a shared purpose, then there shouldn't be that fearful sort of emotion about the quality department, or whatever it's called, if we're all working in an integrated way for a better outcome.
So I want to link that one to the accreditation question that's in the chat. Is where does accreditation fit in with this whole movement of co-production and so on? Because accreditation involves inspection and regulation. It's quality 1.0.
Yeah.
So how can we co-produce accreditation? John, you're on ISCRA board, so you could comment from the ISCRA side. I'm a previous ISCRA CEO. Anyone want to think about that one?
Yeah, I could come in briefly on it. I mean, I'm not an accreditation expert by any stretch, but I suppose I try to be a generalist in every sense. So knowing a little bit about a lot of things where I can. And the discussions in accreditation circles at the moment that I would be in are all about how you link these ideas of 1.0, 2.0, and 3.0. So where accreditation already exists, how can that be a better vehicle for more effective 2.0 and 3.0? And there's wonderful initiatives in accreditation organizations going on around the world in looking at that. How can accreditation change to be a driver of improvement? And I think that's really encouraging. And again, I think it's reflected also in this book. It's about bringing strands together, different schools of thought, different silos that maybe have developed over time, because that's the nature of subspecialization, right? It happens in clinical care too. Silos start to develop, and I think in this book, across different strands of quality and in what's happening now in accreditation and standards with regards to linking those three different ideas together, 1.0, 2.0, and 3.0, I think we're working towards breaking down those silos again for greater effect.
I've added just in the chat, there's one of our co-authors on the multidimensional model, Chris van Hecht, is doing just this, is saying the hospitals in Flanders are saying, well, we've all been accredited 3 or 4 times, most of them JCI accredited, so they're very high level or health quad accredited. What do we do next? That was the question. I say, what do we do next? Because you've met all the standards. And when the inspectors come, we are showing them that we've met all the standards. What's the next level? And this is where we're looking at it, is how we can bring in the multidimensional model to add another dimension to the accreditation experience and allow, and the co-production is hospitals are defining what is quality for themselves rather than the accreditors saying this is the quality you have to reach, because they've already reached that. So it's taking accreditation to another level. And that research is coming out in loads of papers. If anyone wants access to that, just email me and I can get that to you. But we have only 4 minutes left. So I'm going to ask each of you to just give a statement about the chapter you wrote. You each got about 40 seconds each. I'm going to end with Paul, so I'm going to start in the order of the chapters that they came. I'll go first with John. We didn't even get to implementation science, John, so let's mention that implementation science chapter.
Well, Peter, I think a picture tells 1,000 words. So in 90 seconds, I suppose, the most exciting thing about this chapter in implementation science that we've written, I think, is again connecting what was seen as a separate science, a separate school of thought, with improvement and design thinking. So, again, taking what can augment improvement initiatives and bringing these different schools of, improvement science, which is all about synthesis, bringing things together, testing things in the real world, implementation science, which was traditionally more about analysis, breaking down the intervention, the process of implementation, the context to try and understand it better, bringing these different ideas together to boost one another for greater improvements in quality more generally, and really applying the design lens to make sure both can work better. So that's, I think, the most exciting thing about chapter 4, and there's lots of other useful examples in there as well.
And then the next chapter after this is to James on chapter 7. What would you say the key learning from chapter 7 would be?
I think it's a very basic task of just trying to sort of demystify some of the basic health economic terminology for those people who weren't familiar with it. I mean, the concepts behind health economic analysis aren't really that complicated. I think they sometimes get shrouded in language which is not necessarily terribly helpful, and it can get misunderstood. So I think we just wanted to, think about that framework in a very simple, accessible way, and to think about just how it might be tweaked to the quality improvement task, maybe take it away from where it has been developed, as I was saying, primarily around drugs, and just to make things accessible to people, because we're going to have to rely on the practitioners in the field to be able to interpret this. And I would really like to see people, document the improvements that they make, because if there are other winning actors out there who want to see, how they can apply the same processes and consider those outcomes from a health economic perspective, then if those have been documented, maybe according to some of the methods that we've described, then they'll be useful to other people.
That's great. And just to say, James has been working with me for the last 10 years or so, working on with improvement teams just to do that. Pat, your chapters were on getting people on board.
Yeah, so a brief helicopter view is really about the psychology of change. In chapter 10 and 11, it's about your head and the heart and the hands. So how do people think of this shared purpose? Why are we doing this? How are we going to do it? And what do we need to do? And that's basically what chapter 10 and 11 covers, looking at microsystems and how people feel about the work they do, and how we're going to get the job done if we all agree that something needs to be changed.
And of course, people make up systems, which leads us to Sinead. She's in chapter 12. I previously said chapter 10, but it's chapter 12. So, Sinead, any key message there?
Chapter 12 is all about just the emphasizing how important it is to assess your system before you start to do anything in terms of quality improvement, to know what it is that you're tackling, the items in it, the processes, the people, and how that analysis is time well spent, but it's simple to do. But it really is important to understand what's going on in your system.
That's great. And Paul, the last statement brings us to what I'm going to ask you. It's all about curiosity.
Of course. It's about making a bridge between the ideas and the frames in this book and a local setting, and do that with another person, and feed each other's curiosity. Thanks.
Well, I want to thank my panelists. It's an hour done, but actually I want to thank our audience who gave us all the questions. We had prepared questions we didn't even cover. We covered what you asked. So that was a great session. I want to thank all the authors on the book. And I want to thank OUP, Georgiana, and Liz for putting this together so that we could have the session. Just to say, there is a special offer of the book, as you can see up there, for the next week or so. And also, this recording will be available for those who've registered, and we really hope you enjoyed reading the book, and feel out to reach out to me at any time, because I'm available to answer questions. You know where I am on LinkedIn, and I think any of us will be happy to respond to any questions. So thanks very much, and have a great day.
Thanks.
Bye.
Bye-bye.
Team, stay on. James
Yeah.
is gone.
Yeah.
Hi, are we stopped live?
No, we're still recording.
Okay.
Oh no, it says recorded. Sorry.
Recorded.
Yeah, it's done. We're
Finished.
we're not recording anymore.
Not recording, but I think we're still live.
Yeah.
Yeah.
Yeah, 41 people still live.
There.
Okay, that's great.
So it's just us.